Do I recommend to do the bronchs every day? Not necessarily. Again, as I just explained, I think that when they are needed, they have to be with a purpose. But with that being said, this idea that you do the bronchoscopy just when everything is ready to go to the OR and you have an organ donor is really, really not the point. And we actually prove with our data, if you leave the bronchoscopy as the last resort, it's extremely rare that you're going to have any role of that bronchoscopy. If you go when you know that they are going to go into the OR and it's good lungs, they will be good in the bronchoscopy 99% of the times. It will be extremely rare that you find something. And if you just, again, don't do anything for a couple of days, don't do the bronchoscopy, the lungs are completely atelectatic and full of secretions, and you never do the bronchoscopy, and you just do that bronchoscopy at the last minute, again, you are waste 24 or 48 hours, then everybody's pushing to go into the OR. So at least I can tell you that the bronchoscopy should be one of the first things that you should try to get on these patients and these donors, trying to help you on the management of these donors and trying to get to the point of allocation of organs. So this is an X-ray. These are actually cases that we are managing today. And this is one of the patients that, again, I will say this is on the right is from yesterday. You see the data is today by 00014. So this is a patient August 25th today at this time. And this is, well, I will say, a very typical X-ray that you see on donors. It's very rare to see a clear X-ray, so it's the most common one. But things that we coordinate and we teach, again, to our coordinators is look at the diaphragms on these X-rays. So you can see the right diaphragm very clearly. You can see the heart border more or less here. So you say, you know, this lower lobe is not collapsed. We may be okay here. The lung parenchyma doesn't look very well. There is, again, a lot of increased kind of white areas that are mostly diffused in both areas. So this probably is some fluid overload. And it doesn't look like a very focal consolidation, maybe some area of pneumonia here. But then when you go to the left side, this lung is basically completely atelectatic here on the lower lobe. So you just give half of the right or the left lung, very dense area here. You just don't see the diaphragm. And then you go here, this is 0014. And now we have this X-ray at 1048, and still this lower lobe is completely collapsed, and you even see bronchograms here. So what's going on with this donor here? Here has a really deep consolidated pneumonia, or more likely a left lower lobe collapse. This is not a pleural effusion, very unlikely, because the heart, everything is pulling to this direction. So this is one that I will basically say, hey, can you guys do a bronchoscopy and please go into the left lower lobe, wedge your scope and clean up everything and put a bunch of saline and finish the bronchoscopy. Let's try to do a good recruitment with a CPAP of 25 or 30 for 30 seconds and see if we can get this lung re-expand. And let's work on that and see, this is what we work. And at the same time, let's try to do some recruitment and see if we can help to get the lungs a little bit bigger, better expanded, and de-risk this patient as much as we can because there is some component of pulmonary edema. So the bronchoscopy, again, is not an isolated thing that should be done. I think that has to be in combination with everything that is going. And I just answered the timing between serial bronchoscopies. I think that, like in a case like this, if you manage your donor and you did a bronchoscopy yesterday and you still are not very successful with this, you try to at least clear up the airways again and say, now that I know that the airways are not plugged, let's do some recruitment and then let's try to do a lot of percussion and vibration to this left base. Let's try to rotate the patient to the right a little bit to free up the pressure from the left side and see that can help us to reopen this. And that may be the difference of a PAO to 290 to 350. We reopen this lung in here. So I think that's kind of important about that.